Hi friends, hello my dear friends all over the world. It's exciting, totally exciting. The first webinar we broadcast here out of our academy. We want to do something special, not just sharing with you a lecture with some PowerPoint presentation or keynote. No, we want to do a little bit training. First, some technical issues I need to address. We have about 100 participants in the Zoom program, and then we have most of the people coming through Facebook Live, and some people will come over Instagram. So the best approach is Zoom or Facebook Live. It's possible that you can answer questions, and they will be sorted out by my team around me here. We have 3-4 people helping me with this webinar. And so please feel free to answer questions. If you have a very important question, they will be addressed directly during the webinar. If they think, my team think we can answer this question at the end, we will come to this question at the end. So it's going to be a little bit interactive. It's going to be, as I hope, interesting for all of us. And it's going to be something which is done for us the first time. We want to be really, really at the line clinically and also what we present. It's a hot topic. It's a topic I really like to talk about. I like to talk about flap design. Flap design is something which we need every day. Every clinician who does surgery, if it's a periodontist, if it's an implantologist, need to understand what does it mean when he performs a flap. And this is something I want to address today, and specifically, I want to address the split thickness flap procedure. Let's go briefly. The little difference, it's not a big difference, as you all may know. We have today students with us. We have really very experienced guys with us, but still we have to understand together first what we are talking about. So we have here the periosteum on the bone. And the easiest flap design to perform for every clinician is to do a sulcal incision here and then open a so-called full thickness flap, which includes the periosteum. This is the classical full thickness flap we most of the time use when we perform a surgery around teeth. If you want to become a real plastic surgeon, if you really want to go into a more higher sophisticated technique in performing periodontal surgery, you need to be able to do a split thickness flap. And I know exactly, most of the time, when you speak with some experienced guys about split thickness design, you may heard the words like, don't do split thickness flap. It's a nightmare for your patient. The patient is going to have much more pain when you do a split thickness flap procedure. Indeed, if you do the split thickness flap the wrong way, then you have a more painful postoperative phase for the patient. And this is the point I want to address today to you, how or what you have to look at carefully to do the right split thickness design flap. This is what I want to talk about. So when we go back again to our diagram and think about what is written very often in periodontal books, we go back to the classical situation in the posterior area where we plan to do maybe a split thickness flap. The green part is the periosteum on the bone. So when you look in many books, you may have heard or may have read that the split thickness flap design is done parallel to the tooth axis. So you are going to do an incision where you prepare, let me also mark the mucogingival junction here. So you may do that, what is that, you go and try to be a little bit paramarginal and split here. This is a diagram here you very often can see in books. And this, indeed, if you follow these guidelines, you're going to have problems in the postoperative phase. And that's why we need to discuss exactly this issue. That's very important. So when we come to the periodontal situation, or when we come to the periodontium, we have originally 3 different options to cut into the periodontium. So we can cut into the periodontium. Again, always remember, green is the periodontium. So we can cut into the periodontium first sulculum. Then we intend to do a full thickness flap. We can cut through the periodontium, and you may have heard or read this word, marginal. So you can perform a marginal incision. What does a marginal incision indeed mean? Marginal incision is something, believe me, nobody in the world can do. Because this would mean, all of you remember maybe, somewhere we have the so-called margo gingiva. Margo gingiva here at the top. And if you speak about the marginal incision, this would mean you have to make your incision exactly here at the margo gingiva. This would be the second possibility, but we think this is technically absolutely impossible. So for us, we think there are not three options to cut the periodontium, there are only 2 options, and the second option is the paramarginal. So these are the 2 options. There you go clearly paramarginal, and you sacrifice a little bit of the keratinized tissue here. So these are the 3 options which are described in books, and we now go, when we discuss the split thickness flap, to the paramarginal incision. Now let me go back in a second to the last diagram, where I shared with you the problems you create the moment you cut paramarginal and parallel to the tooth axis. Let's think together. Let's have a look together at this drawing. When you do that, when you exactly follow these guidelines, which are described in many perio books, your flap design, when we look at the flap you have created, and let me draw now this flap here in a very high magnification. This flap afterwards looks like this. So this is the flap you create here when you made your flap, designed your first incision parallel to the tooth axis. The outline of the flap. I call this the outline of the flap. And if you do this parallel to the tooth axis, you create exactly this design. Now, let's have a look at this design. What is now the problem? What is going to happen when you do that? And this is obviously, hopefully, for everybody here in our room here, this is a thinned out flap. So you create a flap which is getting to the coronal part thinner and thinner. And all of you know, here's the mucogingival junction, the blood supply in this part of the flap, in the keratinized part of the flap, has not such a well blood supply. So what is the consequences now for the postoperative healing when you create a flap like this? You know, I like to teach you, we like to teach you in a way that we don't want you to do the flap like I say, or like Otto myself say. We want you to understand why you have to think about this, why you have to change your approach. If you understand the reason, the rationale behind what I'm gonna taught you now, then you will do it. If you don't understand why should I do that, or you should never do something because I or my friend Otto Zuo is telling you you have to do it like this. That's not the intention. We want you to understand the biology behind it. And the biology behind it here is pretty clear. Keratinized tissue till here, and the blood supply in this area is not as good as in the mucosa. And therefore, what is going to happen is the coronal part of your flap here will necrotize. So you're going to have necrosis of the coronal part of your flap. That means afterwards exposed bone. That means pain. So simple. I remember the time when I started to do plastic periodontal surgery, I also went to books. I also looked at all these diagrams. I went right away to the patient and I tried to do these split thickness flaps according to all the books available at my time. And honestly, I have to admit that the clinician, the experienced clinician, they were right. It does create more postoperative pain because I created also necrosis. So we have to address this problem now. It's very simple, actually. We need to understand how can we avoid that this is going to happen. And so let's go how we today recommend to do a split thickness flap approach. Let's go back to our drawing, to our periodontium, and think about how we can avoid that at the end you have a thinned out flap with at the end more necrosis and more pain for your patient. Very simple. Something we always teach in our master classes, the first incision in the periodontium needs to be done always perpendicular on the surface. So don't follow anything like you need to be parallel to the tooth axis. This is not the right decision. It's only one thing you have to have in your mind when you think, where is the best incision? Where and how do I create the outline of my flap. Any flap you're going to perform, think about that. So the first incision, and this is not so simple. It's easy to draw, it's easy to understand, but to perform it clinically, it's not so easy. So the first incision, let me draw it in blue. The first incision should be done perpendicular on the surface. That's everything what needs to be at the end in your mind. And now, the design of the flap should look like this. So this is what we want to create. This is where we want to split inside the mucosa, in the connective tissue. This is what you need to have in your mind. The problem is, and this is typically, your problem is exactly here at the top. That's your major problem. How can you achieve this design? Now at the moment, when you think what I just draw here, you say, logical, clear. He's right. Mark is right. That's what I have to do. I understand this now. Let's go and do it. The problem is that doing a perpendicular incision can be done pretty easy. Everybody understands this now and can follow this guideline and will be able to do it. But now the problem is, afterwards, when you look exactly at the design, I should be perpendicular to my first perpendicular incision to go down here. And I need to have, at the end, enough thickness in the coronal part. So for this, to understand this a little bit better and to follow our idea of creating this perfect split thickness flap, we have a very simple exercise. And this comes from another periodontal surgical procedure, namely the free gingival graft. The free gingival graft, when I was taught to do free gingival graft, it was in already 1984, long time ago. I learned this from a very famous professor. This was Merman. He taught me the free gingival graft. At first, he taught me to use the Mucotome. This is a machine where you can harvest the free gingival graft. Today, I always tell a beginner, don't use the Mucotome to harvest the free gingival graft. Take your time and harvest the way you should harvest it, and this is going to help you to become a great plastic surgeon. Why? Because when you look here, what do we want? This part of the flap has the same design, almost the same design, like your free gingival graft. So let's work on that. When we go to the free gingival graft and look at the drawing, when we harvest now in the upper jaw, on the palatal side, we harvest a free gingival graft. This for us is way up the best exercise to become a great plastic surgeon. Again, maybe I make the drawing also occlusally. Excuse me. No, okay. Okay, I do it down here. Here's a premolar, and another molar here. So here we say, okay, this is the graft we want to harvest. Okay? It's the graft we want to harvest here. First thing, very important, that's the same thing when it comes to flap. Do an overcut in the corner. Here, overcutting the corner, very important. Because this allows you to have the equal thickness also in the corner, so that the corner is not thinned out. For the graft, it wouldn't be a problem. I understand that. But for your flap, always have in mind now, we do this exercise now for your future preparation of split thickness flap. That's the idea. When we look now at this occlusive view in a section, so we go through a section here now, and we see now two perpendicular incisions. These are the two perpendicular incisions on the palatal side in the area where we want to harvest the graft now. So, now I draw you the goal. What you want to achieve is clear. There's no doubt about that. What you want to have at the end is a free gingival graft which is equal thick from the top to the base. That's clear. So you don't want to go afterwards on a glass plate and remove, you know, some fatty tissue, some glandula. You don't want that. It would be much better. And also, regarding morbidity for the patient, if you would leave the fat and the glandulas inside the mouth. So the goal, very simple, is this. This is what you want. You want to have an equal thick graft from the top to the base. That's your goal. But most of us do. We have to be honest. Most of us do that. They start here, maybe they start a little bit here, and then they go here, blue, and get thicker and thicker to the base. That's what most of us do when they harvest the graft. It is coronally a little bit thinner, and apically most of the time very thick. And then we put this graft on a glass plate, and then we remove the glandula and the fat. Not clever, not at all. It would be much, much better to leave this part here in the mouth of the patient, which is clearly shown in the literature by a nice study by our friend Rino Burkhardt. So, now look at this, and look at this design here. Exactly the same. Exactly the same. So if you can achieve this here, namely an equal thick graft from the top to the base, perfectly perpendicular from the beginning, if you can achieve that, then you can become a great plastic surgeon. So simple. So we have to discuss this now. Again, it's the same story here. It will be a little bit easier today when we do this now than afterwards on the apple. Here we go perpendicular. This everybody understand. To go perpendicular on the surface. And then we have to do a perpendicular incision to our first perpendicular incision. So this is the difficulty. We cannot do this in one step. I cannot cut perpendicular on the surface like this. And now I take my blade and I cut, like on the diagram, perpendicular to my first incision like this. This is impossible. You are not able to do that. So what we have to learn, and that's now really, really important, how, and we call this, how do we get around the corner here at this first incision. That's the secret. That's the maximum secret. How do we get around this corner, our first incision, perpendicular to the surface? How do I get at this point here, where I afterwards can split down here in one layer? First, that's what you have to learn. And the best exercise, believe me, is harvesting a free gingival graft. So the first thing, and this is human being, I know that. We know that, we have taught so many clinicians around the world. What everybody likes to do is, give me a forceps for a second, or a plier. Everybody likes this here, look. Everybody does this, and the blade. Give me a blade. We have it ready like you. So the first thing, because we are human beings, we have one thing in our mind. We want to see what we do. So, thank you. So when we have a blade, and we work with a blade, we want to see how our blade works. Otherwise, we think we are not safe. This is human being. But this you have to avoid. This you have to put aside. So the moment you do that, as I said, and many like to do it like this, oh my goodness. So the moment, let me clean this up, no problem. The moment you take a forceps or a plier, you hold your graft here, and then you start to prepare. This is what you like to do. This is what you do. The moment you do that, I know exactly what's happening in your mind and what's happened clinically. The deeper you get, the more afraid you are. Down there is something you don't want to cut. And I can tell you, when you do it this way, the deeper you prepare, the thicker you get. That's normal. That's exactly what's happened. And that's why you most of the time harvest like this. So forget the plier when you harvest the graft. This is not the right way. What you have to learn now, you have to learn to harvest the graft with the 15 blade without using a plier. When you're a right-hander, put your left hand on the back, and then you harvest like this. Like an artist. You become an artist. You harvest like this, and you forget to use a plier to hold your graft. Believe me, this is going to help you. This is going to help you. I know exactly, many of you think I'm crazy now. This is not true. It is true. Try it. And we will exercise it afterwards. So that's the first thing you have to think about. So don't use a plier. Second, we cannot cut perpendicular and then the next cut perpendicular to the first cut. Impossible. We already addressed this. So we have to go around the corner here in steps. As a major goal, when it comes to flap design around teeth, is you have to create a flap of a flap thickness of 1 to 2 millimeters. So a flap thickness of 1.4, 1.5 millimeter is the ideal thickness of a flap around the tooth. So that's what we have to achieve. So our first incision, and that's what we want to do now also for the graft. So we want to, at the moment, there are different goals depending on the indication. Sometimes you want the graft a little bit thinner, sometimes you want the graft a little bit thicker. This depends about the clinical situation. But now for the exercise, we say, okay, split thickness flap, we would like to have a 1.4 millimeter thick flap. This would be great. This is our goal. That means we want to harvest now a graft with a thickness of 1.4 millimeter. Now we go with our blade first and we go a little bit deeper. So our first cut, which is perpendicular on the surface, should be done a bit deeper than 1.5 millimeter. So it makes it a little bit easier for you to go around the corner and to create in the corona part the perfect design. So you will see me to show you this all the time now. This is what we want to achieve. Coronally, our flap needs to look like this. If we follow our flap from mesial to distal, let me start here. Now I'm here, okay? This is the mesial, this position of your flap and design, and we go back and look at the flap. This is what we want to achieve. And you know what? We don't want to see this. Okay? We don't want to see this. Thin, thick, thinned out, too thin. All these different designs, we don't want to see that. We want to see a flap from mesial to distal, always exactly the same design. I know this is not simple to achieve, but this is what you have to work on, to exercise. Exercise, exercise, exercise. Believe me, not all my flaps look all the time, every day like this, all the time. I know that. We are not machines. But when we have in our mind, this is our goal, and every day when we do surgery, we think about that design, we become better and better and better. This is what you have to learn. So now we go in most of the time 3-4 steps around the corner here till we are here, and here to go around the corner. Make sure that you do this in little steps and that you work only with the tip of the blade. What blade do we need for that? Clear answer. For this, you need a blade which has a wide surface at the tip. So, for doing a split thickness flap, a 15C blade is not the ideal blade. So you need a 15 blade. Look for a 15 blade, which has a wide surface at the tip. This allows you better to go around the corner. We go in steps, and once we are here, and we are sure we have the thickness at the top, which we want to have, then we try to go in an equal thick manner down there. And now, how can we do that? Before we go now to the exercise, I tell you now how you can make sure that your flap has an equal thickness from the top to the base. Very simple, not so simple, but there are some things we can use that we can achieve that very predictable. We have to go to implant dentistry. I ask you a question, which many of you pretty sure can answer. How thick? Let me draw this briefly. When we have an implant, when we have an implant here in the bone, and now we create here an individualized abutment. This is an individualized abutment. And now we have numbers. In the implant therapy, we know that how thick the tissue here must be that when you use here, instead of a zirconium oxide, instead of a ceramic implant, if you would use here a titanium CAD/CAM abutments, what we used maybe 10, 15 years ago, how thick the tissue had to be that this titanium was not shining here through the tissue. This is a study which was done by a group in Zurich, by good friends of mine, and they did this study and they found out if this flap has a thickness, or if this tissue here has a thickness of equal or more than 2 millimeters, then the titanium abutment is not shining through the tissue. You got it? We take this as surgeon, the same thing. Now, when we split down here, we use what? We use, let me share with you, very simple. We use a blade. What is the blade made of? Metal. So this blade, when the flap has a thickness of more than 2 millimeters, the blade is not shining through the tissue. The moment the blade starts to shine a little bit through the tissue, you are in a thickness of 1.5 millimeters. If the blade is shining completely through, you know what's happened. You are too thin. Great help from the Prostor literature to help us as surgeons. Moment when the blade is shining a little bit through the tissue, I have the perfect thickness which we want to achieve. So this is going to be a little bit difficult on the apple, because in the apple no study was done, so we don't know when the blade is shining through. So this argument you can only use on patient when you work in gingiva. Here it is a bit more difficult, but it's a wonderful exercise. What we are going to do now, we are going now to harvest 3 gingiva graft on an apple, which is, believe me, this is the start of becoming a great plastic surgeon. Okay, let's move on to the exercise. Wie haben wir Zeit?
Wir sind 17:37 Uhr.
Noch, wie lange machen wir, haben wir gesagt? Okay. I need loop first. Oh, I hadn't understood. I have new loops. I wanted to share this with you, but no, let's start. We have now a new loop development. This is an incredible thing. We have now 8 to 10 times, a 9 times modification loop available. It's a very new development. And now we want to exercise on an apple. So the goal, again, we want to harvest on this apple a 3 gingiva graft. So what do? We go with our blade perpendicular on the surface. So this is clear. This is simple and easy. We want to harvest the blade graft which has approximately 3 to 4 centimeters. So this is the goal. Don't harvest too small grafts, not too little grafts. Then we do an overcut. Remember what I told you? We overcut in the corner and we harvest a graft which is approximately 10 millimeter, 9 to 10 millimeter. That's what we want. Don't make it too small also in the bright. Don't make it too small. The smaller you do it, the easier it is for you. So make it really big enough, tall enough. So overcut in the corner, very important here. Remember, my incision was done perpendicular on the surface. My incision was done about more than 2 millimeters, a little bit more than 2 millimeters. So the first incision is always a little bit deeper than your flap design should have. Just repeat it for you that you can see it better. So everybody understands that. But I always try to be exactly perpendicular on the surface. Everybody understand that? I just repeat it that you can see it better. Okay, that's now the outline of our 3 gingiva graft. Now comes the way, how do we get around the corner? So we cannot go right away now. I introduced this to you. I cannot go right away like this. If I do that, I will be very thinned out. I have to go by step. Now in the tissue, let me share it with you briefly. When we go back to the patient, when we prepare a split thickness flap, I wait. Okay, so you see, we are now here. We have done this cut now. And now we need to go at this point to go in there. If you now cut here into this tissue a little bit, that's what I'm going to do. I cut here in this tissue. Doesn't matter, because this tissue later on, I will cut off anyhow. So you can take this a little bit help and cut out a little bit of this tissue here first, that you find the right spot or the right site or spot of the flap where you go into the mucosa, where you go into the connective tissue. This is the point. You have not up here, not here, you have to go here. And so by removing coronally a little bit of the tissue, you make it a little bit easier for you to create our flap, you remember. Okay, let's go back. That's what I'm doing now. We first do a little cut here. We angulate our blade about 30 degrees. And now I cut a little bit in the tissue, 30 degrees. I follow carefully. This I can do as a human. Now this tissue, we take out. You take this out. Very simple, a little cut. Now let's have a look. Now I can see already the point where I want to start to go in the connective tissue. You see down there? This is how I start. Maybe I cut a little bit more sometimes there, doesn't matter. This is exactly the point where I want to go into the mucosa to create at the end the perfect flap, specifically here now in the coronal area. This is the difficulty. So now we have 90 degree, we angulate our blade 30 degree, and now we angulate a little bit more, and we work only with the tip of the blade, and we try now to go around the corner very, very slowly. Here in the apple, the tissue is a little bit more rigid. That's why I cut here a little bit more off. And now comes the moment where I need to work in this direction. I have to work with the tip of the blade, and that's why I need a very big surface here. You remember? I said you need a blade which has a big surface here. You don't want a 15C here. This blade does not have a wide, bright surface here. So you need a blade with a wide surface. And with this blade, I can work another 30 degree and I can start to push the tissue out like this. So now I start to push the tissue out. And I angulate my blade. Okay? And now, even more, I go step by step, trying to create the perfect coronal flap design. Push the tissue out. I go a little bit deeper. Doesn't matter when you cut off a little bit of tissue coronally. This is not a problem. Now more. You see how the flap comes out? How the free gingival graft is moving away from the surface. I am already almost parallel to the surface. Now I am parallel to the surface. And now comes the difficulty. This is the difficulty of the exercise. What is the problem of this exercise now? The problem is that my blade is not shining through this tissue now. So Now I need only feeling. Now I need to try to stay parallel to the surface and carefully prepare the graft deeper and deeper. I bend parallel to the surface. I'm preparing parallel to the surface and push the tissue out like this in this direction, and I go deeper and deeper and avoid any plane. Now look at this. I haven't used any instrument. Now we have a look together. Let's have a look together. Oh, this exercise is absolutely not forgiving. Here I'm a little bit too thick. Take this off a little bit and a little bit here. So now let's have a look. This is the most important part of this flap. This is the coronal part of your flap. You see that? Has a thickness of 1.5 millimeter. You have an equal thickness everywhere. This is the design of your coronal flap. Now let's go around, and you see here I'm not perfect. Here I'm a little bit too thick. This is 0.5 millimeter thick, too thick. Let me check. I want to be honest to you. This is a very difficult exercise. Here I'm a little bit too thin, and here I'm good. So exercise and exercise and exercise. The goal is clear. At the end, you need to have an equal thick graft from the top to the base, and you leave here all the glandular and fat in place, and the patient will have much less pain, believe me. So, what?
47.
Excuse me?
Noch 10 Minuten.
Okay, your question. I wanted. So, let me go back. This is something you should try and exercise and exercise and exercise. The goal is clear. It's a very simple exercise. And today I planned also to do some suturing. This is going to be our next webinar. We will do, soon we will advertise it. Next week, we will do a webinar about All-in-2. This is going to be next week. There we will also show you some practical work we can do. And we are planning already this webinar. And in 2 weeks, we will do suturing. Suturing will be the same exercise. We will start, everybody of us will start to harvest again this graft on an apple. And then we want to suture this flap or this graft back into position. This is going to be our next webinar. I thought that this is going to be too much today to do both, but I can tell you, this is something I exercise with you today, and now you have to exercise at home. You can use any vegetable, any fruit, where you are able to go around the corner, harvesting grafts with a side of 3 to 4 centimeters in the length and about 10 millimeter wide, and dry it. Make sure, and let me repeat these things. This is now really, really absolutely important. This diagram is your goal. This is what you need to achieve. And never forget that. This is the start for every great plastic surgeon, paid-on plastic surgeon. If you understand that, if you understand that your flaps coronally needs to have this shape, not this shape, not this shape. That's what's going to happen. You go too fast around the corner. Your flap look like this. You want this. You don't want it to have too thin. You want this thickness, 1.4 millimeter. So not too thin. Some people make the flap perfectly in the design, perpendicular, but too thin. That's what we don't want. Then after that, if we have the right flap Coronally, we want to prepare equal thickness to the base, and this is not easy. And the first thing I wanted to learn is don't get too thick the deeper you go. This is the major problem of any surgeon. The deeper you prepare, the thicker you get. We don't want that. You want to have an equal thickness from the top to the base. There are many things we are going to discuss in detail in the future on webinars. We are going to help you to understand more and more. This was the starting point. The first thing we teach in our masterclass is this. And we always urge our people, and maybe some of our friends, our family of the Academy, of the Hörsel Academy are there. They know that. How much I say the first incision is perpendicular on the surface. First thing, going around the corner in step. This is not possible in one step. Very important. Try to be in an equal thickness all over the flap. Very important. So you see many, many details, and now I ask my staff and team if they have any special question which I can address, please let me know.
Yes, so Mark, we have a question about your loops. Maybe you can say some words about this too.
We have a question about our loop. Yes, this is the newest design we work on. Actually, we work with 6 times magnification loop with a 35 centimeter working distance, since this is our classical loop, which we use. Everybody has light on it. And now we have developed a new tool with our partner from the industry. And we can add this on top now, as you see here. And now I have a magnification of about 9 to 10 times. It's a future loop. We strongly believe in it. Otto and myself are using it now since 1 year. We are totally excited. One thing I have to say, this is really for freaks, for people who want to get better and better. If you work with this, the problem of this loop, I need to admit, is the depth of field is not so big. So you need to be very strong here in the neck. But if you are used to work with a 6 time magnification loop since already years, 2, 3, 4 years, go in this direction. It's amazing. It's the next step. You have almost, I would say, a microscope on your head. It's marvelous. So for us, we will recommend it. We already recommend it in our courses, this new loop. It's the next step. Like we are developing for those freaks, maybe are here with us. They were here maybe 2, 3 years ago. We have new blades coming out soon. This is another world, my friends. For plastic surgeon, we need new blades. And the new blades we are at the moment developing, and they're already in the market, on the market in Germany. They come on soon all over the world. Believe me, it's going to be a new world, specifically for plastic periodontal surgery. We need it. Actually, there are today surgical approaches we cannot do without our new blade. So we are working on improvement on many areas. This is one, the loop. Other question, my friend.
So you do all of your surgeries with these loops?
Today we work actually, Otto and myself, on a daily basis with this loop. This is our new loop. We work daily basis. Yes. Other questions?
Yes. Why did you go for a semi-lunar incision and not for a rectangular flap? You know, in the outline of the 3-2 graph?
Why did I use a semi-lunar incision and not a rectangular incision to harvest a rectangle? This is just for exercise reason. You can also exercise in a rectangular approach. It's the same. I designed a semi-lunar one when you do a free gingiva graft around teeth. the old fashioned to create more keratinized tissue around teeth, then the semilunar incision is the right way. If you need this graft for other reason, maybe for tunneling, then you have to prepare a rectangular design. But I just did this for exercise reason. Other questions?
Yes, we have a question. When the palate is very deep, how can you make sure you're always going around the teeth 90 degrees? And some people ask about the teeth. Aren't the teeth in the way when you try to go around the corner?
This, my friend, is your major problem. Completely agree. So in this field, or in this aspect, the exercise on the apple is easier because the teeth are not in the way. But as I said, during the preparation on the apple, the tissue on the palatal side is more flexible, much more flexible. So the apple is very rigid. The tissue is more, the normal tissue, the gingiva, the masticatory mucosa on the palatal side is much more mobile and so elastic, so it's easier, and that's what you have to learn. That's exactly the point. This is the major question. To go around the corner, to move your blade here in this direction, the teeth are always in the way. So when I started to share with you, showing that you have to push, give me the blade again, that you have to learn to work with the tip of the blade and push the tissue of the tip of the blade out. This I showed you on the apple. This is what you have to learn. This is the only thing I can say. Keep in mind what you have to achieve. I think everybody understands this now. Now it's about exercising, exercising, exercising. Believe me, it works. You just have to exercise it. Other questions?
In the apple exercise, how big should this graft be in the apple exercise when people now try this at home?
Yes.
In millimeters, what you recommend?
Do it about, this is the length of 30 millimeter, and this is the length, 30 millimeter, and here the wideness should be 10 millimeter. So they don't make the grafts too small. The smaller you do it, the simpler. There's no doubt. If you do it very small, then everybody can achieve what we discussed. If you do it a little bit wider, let's get said, 30, 40 millimeters long and about 10, 12 millimeter wide, then it's demanding. And you know what is the good thing? The good thing about this first exercise we did today, it tells you every little mistake you make. Wonderful. Believe me, you can learn the most out of your own failure. I like this exercise because I saw, even I did this so now many, many, many years. I did it not perfect. It is almost impossible to harvest on an apple the perfect flap or the perfect graft. But the closer you get, the greater for yourself. Believe me. And you will see the first one, you can see all the mistakes I mentioned. You will have a lot of mistakes, believe me. If you are critical enough to yourself, that's what you have to be. Please, be as critical as possible to yourself if you do this exercise. This exercise shows you all the mistakes you make. Be critical and exercise. Then it will help you a lot, believe me. Do we have another question?
Yes. Could you explain again why you do these overcuttings at the corner? People
okay,
ask this.
Good question. Very important issue. Why do we do always when two cuts come together, you have to overcut? You know, we are, again, humans think we are only good surgeon when we work like this. So we think this is much better because now we have a perfect cut exactly in the corner. But now think about what's happened in the deepness. If you do the cut with a round blade, remember, this is the round blade we use. If we cut like this perfectly. In the deepness, we do not cut thick enough. We don't cut completely through in the deepness. And this is a big problem. This then creates at the end, so in this area here, we will have a thinned out flap. And this is now later on when we come to the flap around teeth. And then we go back to this picture. Look, that's a picture I put here for you guys. That's the papilla we want to create. If you don't overcut here perfectly in the papilla, you will never have this design. This is your goal. What you can see here on this picture, this is the goal, what you need to achieve when you do split thickness flap around teeth. So we have so many questions.
Yes, we have some more. We are working on a very high magnification, like 8 to 10 times. Why do you not go for a microscope?
Yes, microscope we use. Why don't we go for microscope? The problem is, you know, there is a tendency today that we go a little more to the microscope today because we can do periodontal surgery today also more and more for one side. More and more we can do surgery from the buccal side completely. In a moment like this, when we have, like the endo guy, we can concentrate on one position of the microscope, then it does make sense to use a microscope. The moment you have to start to move to the palatal side, to the buccal side, to the palatal side, to the buccal side, and always adjust the microscope to this different position, it takes too much time. And that's the reason why we develop these loops today. In this situation, we are more flexible, and don't forget, speed, time is always an issue for healing. So if it takes you too long to perform the surgery, you cannot expect the perfect result. So time is always an issue when it comes to surgery. There's no discussion about that. There's a lot of evidence about this issue. So you have to really decide yourself. And I can see a tendency in our clinic to more using the microscope, exactly because we can concentrate today more and more just on one interproximal area. But I think we need to stop now. We have so many questions going on, but I would say, I think we should stop now. I would like to thank you all being part of this adventure for me. I think I'm very happy. I'm excited. I can bring my emotion to this topic over. That's my major goal. Otto and myself, we are so excited about dentistry, about being as perfect as possible, working on ourselves. How can we become better? And we want to transfer this to you guys. We want you to create the same passion for this really, really wonderful profession we all have. And hopefully we see each other soon again. Next week about All in Two. In 2 weeks, we go ahead with this seminar, with this webinar, with suturing techniques, how to suture. Believe me, suturing has changed a lot today. Has nothing to do how we sutured 15 years ago. I'm looking forward to see you there, my friends. Have a nice evening.